Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, one word.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. My guest today is Dr. Christian Rolfo, Professor of Medicine and Director of the Thoracic Medical Oncology Program, as well as Director of Early Clinical Trials at the Marlene and Stuart Greenbaum Comprehensive Cancer Center at the University of Maryland School of Medicine in Baltimore. Christian, thanks so much for joining today.
Thank you, Jack, for the invitation. It's a pleasure to be here.
I like to always start really at the beginning, going back to childhood and where you grew up, what that was like, and whether you had an interest in medicine early on. Did you grow up in Argentina?
Yes, I was born in Cordoba, that is a second city of the country. It's in the middle of the country, actually, and it's very known by the university and all the studies that we have there. So I grew up there. I did my MD there, and I moved when I was 25 years old to Italy.
So let's get to that. But before then, you list both Spanish and Italian as mother tongues. Were your parents from Spain or in Argentina and Italy? How did they meet?
So no, my family is second generation Italian. So they arrived, my grandfathers arrived there in Argentina. So they are from a big colony of people. It's coming from the north of Italy. The region is called Piedmont. The capital is Turin. And these people arrived all together in the beginning of the century to Argentina. And they create a big colony of people that they maintain still the language, the dialect that they were speaking in Italy. So both my mother and my father, they came from this kind of roots, Italian roots. So actually at home, they continue to speak some of the language of the dialect.
And you grew up as Italian there, yes?
Yeah, I think, that has happened with several Argentinians. I think you have a duality inside of you because from one side, you are Argentinian, you're born in Argentina, and you have all the customs of the country, and you love your country. But at the same time, you also love the nostalgia and the memories of your family coming from Italy. So your food is Italian, your way to thinking is Italian. And I think it's something that you bring inside of you until you arrive to Italy and you discover that it's home. Also,
well, how do you approach the World Cup?
First of all, I'm Argentinian, and then I became Italian if it's not a good opportunity for Argentina. But no, I think it's I'm going for both, actually. The problem is at home because my wife is from Spain, so that's another conflict that we have.
Okay, very good. So going back, did you have an idea early on that you wanted to go into medicine, even in childhood, or did you have physicians in your family? Was that an expectation, or did that come much later for you?
Yeah, it was my own idea because my family is nothing to do with medicine. So when I have, and that's always my mother remember, when I have 6 years old, I told to her I want to become a doctor and go to Italy. So I think I have the things very clear from the very beginning. I never have other idea to be more than doctor. So that was my willingness from very, very, very beginning when I was child.
Were your parents very supportive of you moving to Italy? I mean, obviously they had that cultural connection, but I presume they were still in Argentina. How did they feel about you moving to Italy? And was it with an idea of you staying in Europe or in Italy long term?
Yeah, the thing was born because I get a scholarship from the Italian government to go there for people that is having the passport from Italy. We have the opportunity to go there for a period of time to make a kind of experience in a university. And I got the opportunity to get there at the university in Italy, in Milan, and the National Cancer Institute, and was for 8 months. But I know from the very beginning that I don't want to back. So I was trying to stay there, and finally I get the opportunity to get there with one of my mentors, Dr. Luca Gianni, and I spoke with my family, and they were very, very supportive. Obviously, they came immediately to Italy. I was 25 years old, and it's not the same period that we are living today. And we don't have WhatsApp, we don't have all the things that we have today.
Right.
And they traveled there. They saw the conditions where I was living, and they were 100% supportive. So I always thankful for that for my family.
You pursued a PhD, and I believe that was in Italy as well, right?
Yes.
Can you explain whether the PhD was really just part of what you needed to do clinical research as a physician, or was the PhD component something extra that you wanted to do above and beyond because of a strong commitment to research beyond what might be required to do clinical work as an oncologist, for instance?
I think it was beyond, because obviously I was doing in the beginning before I moved from Argentina, I get the opportunity to start my fellowship in my country, and I was doing 2 years. The third year I went to Italy, and the idea was in the beginning to back theoretically. When I arrived to Italy, nothing what I was doing in Argentina was able to be convalidate, so I need to start from zero again. And I did at that time were 4 years of a specialization of fellowship, we'll say. And when I became oncologist, I say I would like to focus in research. At that moment, I have the opportunity. It was a very special moment in oncology, because I have the opportunity to participate as a fellow in some of be in the moment that all the trials with imatinib were coming for the GIST. I was working at that moment with Paolo Casali, that is one of the big names in sarcomas. And I saw these targeted therapies going to change they were changing the life of the patients. And I say, I'm interested on that. So after a certain period, I moved from Italy to Spain, and I meet Rafael Rosell. And he was my second mentor, I will say, and he was incredible. So he opened my mind to lung cancer research. And I say, I need to do a PhD, and I want he is my tutor. Actually, he was my tutor together with an Italian professor, Professor Antonio Russo. And I was working with them in the EGFR mutation. Actually, my PhD was on that, EGFR mutations, and PET at this moment was something that was very innovative. And I think the PhD gave me the opportunity to entrance in contact with the translational part that I was not having in my clinical fellowship. And that is something that is a tool that I still am using in my own lab. So I was never in the lab putting my hands, but I'm a part of the bridge for the clinic and the translational. So, and these are things that I was taking from the PhD, absolutely.
And I'm impressed with how much breadth you cover, that you really do bridge between the more lab-based and the more clinical. Even your PhD was pretty practical work. And then you went to Valencia, Spain, and got an MBA, as if you needed to cover more ground. Can you talk about, was that one of the practical issues with your wife being from Spain, or what was the concept of both getting an MBA and going to Spain at that time?
Yeah, I went to Spain before for work, and I have the opportunity to get this PhD in the bridge between Italy and Spain. And then when I finished that, I was living in Mallorca, that is a beautiful island, but I like to have more research things. So there was not easy to have this kind of part of research, and was an opportunity to continue to study. I want to study and do more things, and it was an opportunity through the board of physicians in that region that they engaged the university, Polytechnic University in Valencia, to have this MBA course that we have. Actually was very good because we don't need to travel to Valencia. The teachers and everything were coming to our region. So it was a very nice opportunity. For 2 years, we get this MBA. Actually, I think it's also another tool that you get. You can get several important clarifications for your your work as a doctor, as a clinical trial manager, and all this kind of concept and language that the business people is talking, you are able to understand. This is not my first focus, or will not be never my focus of interest to be using this as a primary tool, but I think it's important that you get this concept if you want to be in a position to manage a group, or at least to have your own research group as well.
Did you have an idea of what you wanted to do long term as a career at that time, or were you collecting experiences and skills and kind of seeing where that took you?
I think it's the second one. So I have clear that I want to do clinical research. Obviously, it's not easy to coming from the clinic to start from zero there. So you need to collect experience. You need to collect also knowledge. And I'm very thankful because all the experience that I was having in Italy and then in Spain and the Spanish lung cancer group and be part of societies and are all these things are making your career and arrive to the goals that you are creating, no? And I think you need to go step by step. That was my case. Maybe this recipe is not useful for everyone, but my experience was, or my life experience was, that having this knowledge, acquiring this experience is making step by step, building up your career, and also focuses in what you want to do in the future.
I noticed that you were an oncologist in Mallorca for many years, from 2003 through 2012. And during much of that time, you were also working as the head of the phase 1 early clinical trials unit in Antwerp, Belgium.
After that.
It was not overlapping.
No. It was after that. When I moved from Spain to Belgium.
Okay. So what led to that? And were you not intimidated by the idea of moving to a different culture, a different language? I mean, I'm really impressed. I think it's one thing to go from Argentina to Italy when, you have this cultural identity and affinity for, you are familiar with the language, Italian and Spain, but something different to go to Belgium and then work in this entirely different environment and need, I guess, to pick up a new language, right?
Yeah, that's correct. So it wasn't a decision that I was thinking a lot. I have the support of my wife. From Italy to Spain, I get married. My wife is a lawyer, criminal lawyer. She's working a lot in Spain. And we decided, she was seeing that I want to do research, and there I was not able to do all the research that I want to do. So I was looking for some opportunities. I did a profile in LinkedIn, and I started to receive some opportunities from the headhunters. One of them was from Belgium. And I was very, very motivated because I saw that the team was very good. The head of the department at this University of Antwerp, was Dr. Mark Peters, that is a very known GI oncologist. And also the history of the place, there was also Dr. Vermorken, that is a very known also in head and neck cancers and ovarian carcinoma. So the place was with an oncological background. And I say, okay, we will start from zero. It was very difficult. I have at that moment almost 40 years. I start from a language that is completely different from my origin, and also from the language that I know. So start from zero with Dutch was really complex. I need to be really honest.
Yeah. I mean, you could maybe make it harder by going to Germany. But I don't, I look at, I'm impressed by the range of languages you speak, but obviously Spanish and Italian have a lot of similarities in
Yes, and
Portuguese
Portuguese as well.
and Catalan. I'm a little
Yeah.
disappointed I couldn't go further in Barcelona with my rudimentary Spanish, but still, these are all more similar than different. And then Dutch is a total curveball. I mean, it's impressive. You
Yeah.
have to have some courage. And I'd say both about the language and just about moving out of your comfort zone culturally.
Yeah, obviously, I have a very good job in Spain. I have I know the people. The place was very good. The colleagues from another institution. We have a network. We was able to work very well. My wife is from there. She was working there, so I have a comfort area. But I want to do also some things that are motivating me more. So I know that it's difficult sometimes to understand the decisions, but I didn't regret to move to Belgium. It was a very good experience. It was a cultural shock, obviously, because not only the language, but also the mentality of the country is different. The way that they are working is different. And I saw that like a platform for increase my career. I have the support of my boss there, and I have very good friends. I was able to create a phase 1 unit from zero, and that was really good experience. I was able to work in a team with molecular pathologists, creating more things regarding to lung cancer, molecular profiling. We was able to do first in human, including first dose of first in human, that are experiences that are very important for your career. So I suggest, and that is my humble advice for young people, don't stay in the place that you are studying and do all your career there, because there is a world outside, and you can get several nice experiences. Obviously, it's not easy. It's not something that you will be happy all the time, but it's something that you will, for sure, will enrich your life personally and also your career.
I think that's a big theme, a big question for many people about whether to follow the path, especially if you are having success where you are. And inertia is powerful. You grow roots, you have family connections, maybe kids in school, and just a certain level of comfort in what is familiar versus risking leaving for something else. And you never know if it's going to be the best move ever or potentially a misstep. It's a challenge for people to know that there is this concept in academia or even in business. You have to move up. I don't know that that's exactly true, but I think for you, you've collected a lot of opportunities and experiences over the past couple of decades.
Yeah, and you need to have also the support of your family. I was very lucky that my wife understood my way to work and my brain, how I am thinking now. So it was not easy because we was living separate for 5 years and a half, so traveling and commuting all the time. So I know Ryanair better than other companies, even than the pilots.
But that's probably the biggest challenge, I think.
Exactly. But was a very good experience, and actually, then when we decided to move United States, and this is another chapter of my life.
Of course,
it was a chapter that we can start together because that was the idea to move here.
Well, so let's talk about that, because obviously for all of the moving you've done, a couple of continents, several countries, languages, experiences, the move to the U.S. is a big thing. And that was, I guess, in 2018. Was that part of your thought and plan with your wife all along? And what led to this idea, after all the places you'd been, to move to Baltimore and the University of Maryland?
So it was the conjunction of two things. To be honest with you, I was always putting my career on top of everything, and it's difficult. You arrive to an age that you want to continue, and also because you was working very hard, like you was working very hard. So you trying to continue to be on top of your career, but you want also to integrate something as a family and personal life again. So And a certain moment is something that you need to reconsider because his career is good, but family is first. We need to try to put that first. So we discussed very deeper with my wife, and somebody of us need to finish with the career. She is a lawyer, and working from United States will be impossible. So she decided to support me, and we decided to come here. And also, that's from the family point of view or personal point of view. And from the career point of view, I always was considering the opportunity to come to the United States because the opportunities that we have here in terms of research and the networking, I think are a little bit higher that we have in Europe, or the opportunity that you can have here are different. So I'm very happy to the decision that I took. At that moment, I was contacting Martin Edelman that he was leaving this institution to go to another institution, and he was very kind. He opened me the door also of the possibility to come here. And University of Maryland was also very supportive. I have the opportunity to come here, putting together the two areas of expertise, drug development and thoracic oncology. So obviously, when you start from in a place, it's difficult, new language as well, but that's not a problem. But the English is the official language. But I think the problem was the epic for me until realize all the bureaucracy and all the companies, insurance, and all the things. But that is part of
welcome to American healthcare.
Exactly.
You're really not at any disadvantage relative to every other physician. So
I know. Yeah. I say I arrived late because all the people that was growing in this system is easy. For me, with 46 years old, arrive here was a little bit more complicated, but I'm happy to do it. So it's a good experience.
One thing I noticed when reviewing the range of your publications is that probably because you have been involved in phase 1 work, early clinical trial development, that you have published on and presumably seen and treated patients with a pretty broad range of cancer types. Mm-hmm. Can you talk about what that was like and how appealing or not as appealing it was to treat many different tumor types? And then related to that, what led you specifically to focus on thoracic oncology?
Okay, so I think obviously when you are doing drug development and specifically phase 1 trials first in human, the idea of these trials is also to include several tumors. So I think it's a very unique opportunity because you are in contact with different behaviors, different kind of disease that you need to know. And I think it was a very good opportunity. It's nice when you are able to work in a system that you have the cooperation or collaboration of the other focus of expertise. Obviously, you will not know everything about GI tumors, know everything about breast cancer tumors, but you have the support of these sub-investigators that can help you to understand some of the things. And you also cooperate with your expertise in the process of the drug development and the clinical trial. Why I was focused in lung cancer? Well, when I finished my fellowship in Italy, I have a good expertise in sarcomas, but I knew at that moment that if I want to focus in sarcoma, I will not only need my knowledge, but I will need the big support of a big team, because sarcomas are one of the most complex tumors. I think that you need to be in a very good team with surgeons, pathologists, and so on. So not all the institutions are able to have that. When I moved from one center from Italy to Spain, and also you need a big number of patients to have your expertise in top. No, so when I meet Rafael Rosell in Spain, I start to get my interest in lung cancer because I saw several patients with lung cancer. And then I think it was the right moment because the molecular thing was starting there, from EGFR to ALK and ROS and so on. So that is the way that the pathology or the disease engaged me. And I'm very happy because we'll pass to be the boring ones to the most fascinating area of the oncology right now with all the advance that we had in the last 10 years.
I'd noticed that you'd been living and working in Europe for many years, up to just a couple of years ago, and you're also very involved in the Oncology in Latin America Association, and were a co-chair of the Latin American Lung Cancer Congress back in 2016. Do you still feel a clear connection to the Latin American lung cancer community and broader Latin American culture?
Sure. I think we never need to forget where we come from. There's something that is part of my identity, and I would like to also to collaborate with them. So I have several colleagues that they are in contact with me, and we are sending message about some molecular profiling. I help some of the people to get the reporting there. We was working together to get drugs also there in case that we have, for example, track fusions. So it's a very important that we cooperate with this, with your region, no, where you're coming from. So we create with some years ago with Luis Reyes and Edgardo Santos the opportunity to collaborate in several countries. We was creating a kind of group that's called OLA, Oncology Latin American Association. And the idea is to bring to this region the education in focus in our language, focus in the necessities that the region have, and the idea is to cooperate. So I'm traveling a lot to Latin America. I'm connecting a lot with the people, and I hope that I continue to do that because it's part of my identity.
It's interesting you do so much translational work, and I would say that one of the biggest challenges we experience in the US right now is the, I believe, growing gulf between the best knowledge and treatments available through molecular testing and execution of targeted therapies and just the latest information as coming through tertiary care centers and the broader application of this in the rank and file community setting, because it's hard to get that information out there, a few hundred miles away or even less than that. What do you see as the biggest challenges from what you have seen or hear and discuss with colleagues in Latin America in terms of administering the best treatments available? Is it a lack of just resources, affordable drugs? Is it the knowledge not getting out, educational opportunities? Is there anything that clearly emerges as the greatest challenge in several Latin American countries? And is it different from what we have here in the US?
I think it's a very good question. So I think you have several factors that are contributing to that. One will be obviously the lack of testing. So not all the countries and not all the hospitals have the opportunity to have panels of next generation sequencing, and or even though some single determinations are very difficult to get there. But the reason is also not for the lack of knowledge of the doctor. I think the reason is because you don't have access to the drugs, or you don't have access even to have clinical trials open in time. So if you offer a trial in one institution, for example, in Brazil or in Argentina, will take almost 9 months to 1 year to open the trial. And that's happened also in Chile, or it's happening in Peru. So this is making the region not attractive for clinical trials, and it's a missing opportunities for increase the access to the drugs to the patients in the region. That is not different what is happening also in other countries and in other regions in the world. If you go to Europe, next generation sequencing is not at the access for everyone. There are some countries like France or Belgium that they are having some panels that are paid by the government, but majority of the other countries is the patient who need to pay if we want to do, for example, a liquid biopsy or a next generation sequencing with a big panel to include them in a clinical trials or to have access to the new drugs. So I think we have a disparity situation around the world. We have good drugs, we have good targets, but we don't have a testing. And then you have the other counterpart or paradoxal situation that countries like in United States that you have access to all that, there is also lack of, I think, I can say it's not education, but there is lack of information from some of the doctors that they are not testing all the patients. So I think we need to invest a lot, not only in education, but also in politics. We need to have more. That is for, I'm speaking about the around the world. I mean, in change some access to clinical trials, accelerate the access to clinical trials, improve the access to drugs for patients, and also have the opportunity to test the next generation sequencing or different targets for the patients. Because otherwise, it's like having a Ferrari without driver license. So you have a good drug, good targets, but you don't have the access. So it's crazy.
You're the vice president of the International Society of Liquid Biopsy. I presume that's a pretty new professional society. And liquid biopsy research has become a growing emphasis of your own professional focus and also the broader cancer community. Can you describe some of your work on exosomes in particular and what you see as the potential clinical significance of this research?
Yeah, liquid biopsy obviously is a hot topic. There is an interest specifically in lung cancer because we was collecting data that are making very robust topic, and we have more and more opportunities to use that in the clinical practice. So free DNA is obviously part of our clinical practice, and we use that for detect not only the primary mutations or fusions, but also to get mechanism of resistance and to real-time monitoring the patients. So what we are doing in our research in our lab, we are focusing exosomes that are these microvesicles that are helping to understand a little bit the biology of the cancer cells and the cancer behavior itself. Exosomes is a new concept. I will say extracellular vesicles because otherwise the International Society of Extracellular Vesicles will say that I'm not with the, with the definition. But it's very interesting. We are working in different lines. One of the lines is mechanism of resistance mediated by exosomes of TKI. Another one is the immunocorrelates for distinguish which patients are able to have a better response or to immunocheckpoints inhibitors. We are having a very nice data from there. We are trying to get finalized the publication now, and we just get accepted for another publication in scientific reports about the methods to improve the methods of visualization, also that are opening the door for a therapeutic opportunities because we understand how they are internalizing in the exosomes in the cells. So it's a complex. I don't believe that exosomes never will be changing the role that free DNA have as a biomarker, but it's a very good tool to understand the biology of the cancer and also other pleomorphic activities that they have, including the cancer interception, that is a new concept in oncology.
Where do you see liquid biopsy being used differently in 2 or 3 years compared to now? Is it just going to be incrementally more accepted, maybe at the time of initial diagnosis when tissue isn't readily available? Or do you see it having enough data to assess response to treatment that it could become more widely used in that setting or other areas?
No, I think the clinical application is already here. So we are detecting several of the targets. We don't need to forget that especially in lung cancer, it's difficult to get biopsy for all the patients, and the material, the tissue material, is not always the best one to perform a next generation sequencing. So we was collecting data from in this period of time from different trials. One of them is the Nile trial. The others are also experienced. Like, for example, you interview also Charu Agarwal, that she was doing a very nice work in the real world data. So there are more and more evidence that make that the liquid biopsy is already here, and we have a very good concordance between tissue and liquid. So I think that we can use liquid biopsy, and we was preparing that in the ILCC statement in 2018. We are now in the new one in 2020 because the thing is very dynamic. The field is very dynamic and changing a lot. So I think we can apply from the very beginning for discover which kind of alterations are there, but you will be surprised when you start to apply that in serious time points in patients that are during the treatment. So we are able to catch alterations that are mechanism of resistance that we can completely change the treatment of the patients in time. And that is very fascinating, I will say. Obviously, the new frontier of the liquid biopsy will be the minimal residual disease and the opportunity to have an early diagnosis of lung cancer with the liquid biopsy. And there are several groups that are working on that as well.
Well, absolutely. I think I'm impressed how not just in lung cancer, but in colon cancer and breast, there is a lot of converging, though still imperfect and limited data about the clinical significance of detecting minimal residual disease through a plasma test after surgery, which we could really use in lung cancer to try to prioritize which patients we should strongly favor getting adjuvant therapy, trying to identify which patients after chemoradiation may be cured, which ones need more or longer therapy. I think that the opportunities and the potential to refine how we treat is extremely attractive, but we do need to make it economically feasible and not prohibitively expensive to be doing this many times. Yeah.
I fully agree. And also we need to, so these kind of new molecular tools are also bringing other necessities like molecular tumor boards to really understand the interpretation. We cannot fully follow what the vendors are telling. So we need to also use our knowledge and integrate that in the interpretation. So there are several things that also need to be in place that make this tool really useful for the patients and to follow these opportunities, no?
Absolutely. Where are your parents? Where's your family now? Are they in Argentina? Are they in Italy? Or have they moved somewhere else?
No, my family is in Argentina. I have also family in Italy. I have also family in Spain for part of my wife. So we are traveling. That's the problem when it's Christmas or New Year that you need to go to one place or other. So, but yes, they are here and there.
And they are happy to sometimes come to the U.S. then for a visit?
Yes, they came. So my father unfortunately passed away in 2011, but my mother was traveling all this time. She came several times to Europe. She never came still to the United States because we prefer to go there and meet more family.
Right. Yeah.
But my sister was able to come, and so we are lucky that we can go to see them.
Yes. One last question. Now, you've seen and worked in many different healthcare systems and countries from the inside. Do you have a sense that any one or two of them work particularly well, effectively in terms of access to care and the best available novel therapies? I don't mean investigational as much as just cutting edge evidence-based treatments, that could include the US. But frankly, I don't think that the US is what anyone's idea of a great functioning healthcare system looks like. Have you seen it anywhere in your life's work?
So I think it's a very good question. It's difficult to answer because obviously every country that I was working and every society is completely different. So, and also the intrinsic mechanisms that you have are completely different. That they are, so in United States, it's difficult for me to thinking about a system like is applicable, for example, in Belgium, because all the system in Belgium, the tax payment and all the social involvement of the system is completely different. So what I say that in the difference that in the system, obviously between Europe and different countries was similar. The access to the drug was similar between Belgium, Italy, and Spain because the systems are much similar. Here in the United States, obviously, we don't have a system that is open for everyone. But what I saw here in the population that we are treating here in Maryland is obviously there are several disparities. And the good thing that I saw here that the university is treating to cover everyone. So we have patients with non-coverage, and they are treated here. And so it was something that was a good surprise for me, because when you come from other countries, you have another idea about what the system is when you're going to a kind of pay system. No, so I think that in both areas, in the United States and Europe, there are things that could be improved. And I hope that what we want, everyone's, that we are caregivers and health providers, we would like to have, obviously, non-distinction between the patients and have an access for all the patients in the equal condition. So that is my hope for the future. And I would like to see that all the patients have access to everything in all the world.
Well, I think that's a great goal. And Christian, thank you so much for taking the time today. And I want to give you particular credit because I think it takes courage and a certain presence of mind, both in terms of your professional and your personal life, in terms of going to new places, expanding your horizons in a way that a lot of us are not as open to doing. And I think that's really broadened the opportunities that you've had and the world that knows you. So I really appreciate your taking the time, and I look forward to seeing you at an upcoming meeting. I think I would historically say, I'll see you at ASCO. I don't know exactly what's going to happen, but whenever that is that we can see each other in person, I hope to be able to shake your hand, even if we have to take 20 seconds to wash after that. But it'll be really great to see you personally. So until next time, I'll just hope to keep up. And, there's going to be so much more new material coming out that hopefully we can talk again.
Thank you, Jack. Thank you for this opportunity. I'm very happy to have the opportunity to work with different colleagues here, and I hope that we can collaborate in some projects together.
That'd be great.
And I hope to see you soon, and try to be safe. That's
yes,
the
you
most
too.
important
Yeah.
thing.
It might be on webinars a lot more than it used
Exactly.
to be. All right. Well, you take care. Be safe, okay?
Thank you. Do the same.
Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.